So the present algorithm are based on patients who were diagnosed and included in studies before 2014. So at this time, imaging was imperfect. So MRI was not available for every patient, or PET-CT was not available. So you missed several patients with bone disease, and this, of course, had an impact on survival and the impact on transformation rate. So in our publication, we highlighted this problem, and when you look at new studies, the time to transformation is much longer than it was before. So when you look at the study from Greece and other studies showing this issue. So smoldering, why is it important? Because the old definition qualifies a patient as high risk, but that is not true in our times. So you have to exclude those with bone diseases in order to find really patients with high risk. And this is still complex because it depends on the molecular structure of the patients. But I'm very optimistic that research will define this group of patients with smoldering patients with high risk much better than they can today. But as the simplest version as a clinician is to look at evolving parameters. So a patient who is considered to be high risk smoldering can be followed, and you look at the changes in hemoglobin, you look at the changes in paraprotein, and if there are significant changes, it's clear that the patient is evolving, and in other words, he or she is a candidate for starting therapy. So that's important.